Question 1. To address the challenge of optimizing patient outcomes and minimizing complications in a neonate initiated on ECMO for severe respiratory failure, which of the following management strategies best reflects current best practices and regulatory expectations for a neonatal/pediatric respiratory care specialist, NPS? Option A. Manage ECMO settings independently, making adjustments based on personal experience without consulting the multidisciplinary team or reviewing recent laboratory data. Option B. Postpone any significant adjustments to ECMO flow rates or sweep gas settings until the patient demonstrates a clear and sustained deterioration in vital signs to avoid unnecessary interventions. Option C. Primarily rely on the neonate's overall clinical appearance and the absence of overt signs of distress to guide adjustments to ECMO settings and supportive therapies. Option D. Continuously monitor anticoagulation levels and adjust infusion rates based on laboratory results and clinical assessment of bleeding risk, while also vigilantly assessing oxygenation and ventilation parameters to ensure adequate gas exchange and minimize ventilator-induced lung injury. The correct answer is D. Continuously monitor anticoagulation levels and adjust infusion rates based on laboratory results and clinical assessment of bleeding risk, while also vigilantly assessing oxygenation and ventilation parameters to ensure adequate gas exchange and minimize ventilator-induced lung injury. Explanation: this scenario presents a professional challenge due to the critical nature of ECMO management, where rapid and accurate decision-making directly impacts patient outcomes and requires adherence to established best practices and regulatory guidelines. The complexity arises from the need to balance aggressive life support with the potential for iatrogenic complications, all within a highly specialized and resource-intensive treatment modality. Careful judgment is paramount to ensure patient safety and optimize therapeutic efficacy. The correct approach involves a comprehensive, multidisciplinary assessment of the neonate's response to ECMO, focusing on objective physiological parameters and evidence-based management protocols. This includes vigilant monitoring of anticoagulation, oxygenation, ventilation, and hemodynamic stability, alongside proactive identification and management of potential complications such as hemorrhage, thrombosis, and infection. This approach aligns with the principles of patient-centered care and the regulatory framework governing advanced life support, emphasizing continuous quality improvement and adherence to established clinical pathways. Specifically, the Neonatal/Pediatric Respiratory Care Specialist, NPS, is expected to operate within the scope of practice defined by relevant professional organizations and institutional policies, which are themselves informed by national guidelines and regulatory oversight bodies that mandate evidence-based care and patient safety. An incorrect approach would be to solely rely on subjective clinical impressions without objective data to guide management decisions. This failure to systematically assess physiological parameters and adhere to established protocols represents a deviation from best practice and could lead to delayed recognition of critical issues or inappropriate interventions, potentially violating standards of care and regulatory expectations for competent practice. Another incorrect approach would be to delay necessary adjustments to ECMO settings or supportive therapies due to concerns about resource utilization or perceived patient futility, without a thorough, data-driven reevaluation. This can lead to prolonged periods of suboptimal support, increasing the risk of irreversible organ damage and contravening the ethical imperative to provide the highest possible standard of care within the established indications for ECMO. Regulatory frameworks often emphasize the need for timely and appropriate interventions based on objective patient status. A further incorrect approach would be to manage ECMO in isolation without consistent and effective communication with the multidisciplinary team, including physicians, nurses, and other allied health professionals. This breakdown in communication can lead to fragmented care, missed critical information, and an increased likelihood of errors, which is contrary to the collaborative and integrated approach mandated by regulatory bodies for complex patient management. The professional decision-making process for similar situations should involve a systematic, evidence-based approach. This includes 1. Thorough initial assessment and identification of appropriate ECMO indications. 2. Establishment of clear treatment goals and benchmarks. 3. Continuous, objective monitoring of patient parameters. 4. Proactive identification and management of complications based on established protocols. 5. Regular multidisciplinary team conferences to review progress and adjust the plan of care. And 6. Adherence to institutional policies and national guidelines for ECMO management. Question 2. The review process indicates a need to evaluate the understanding of critical lung development stages in neonates. Considering the embryological progression, which of the following represents the most significant functional advancement for efficient gas exchange that occurs during the later stages of fetal lung development, prior to birth? Option A. The establishment of a fully functional diaphragm and intercostal muscle support for spontaneous breathing. Option B. The formation of the bronchial tree and conducting airways. Option C. The significant increase in the number of alveoli and the development of a mature capillary network surrounding them. Option D. The complete maturation of surfactant production and its uniform distribution throughout the lungs. The correct answer is B. The formation of the bronchial tree and conducting airways. Explanation. The review process indicates a need to assess the understanding of critical developmental milestones in neonatal respiratory care, specifically focusing on the interplay between embryological development and the functional maturation of the lungs. This scenario is professionally challenging because it requires the clinician to integrate knowledge of complex biological processes with the practical implications for patient care and the ethical responsibility to provide evidence-based interventions. Misinterpreting these developmental stages can lead to inappropriate clinical decisions, potentially impacting patient outcomes. The correct approach involves recognizing that the development of alveoli and the vascular network are crucial for gas exchange efficiency. Surfactant production, initiated in the later stages of fetal development, is essential for reducing surface tension and preventing alveolar collapse. Understanding the timing and sequence of these events allows for targeted interventions, such as antenatal corticosteroids, to accelerate lung maturation when indicated. This aligns with the ethical principle of beneficence and the regulatory expectation of providing care that is consistent with current scientific understanding and best practices in neonatal respiratory care. An incorrect approach would be to focus solely on the presence of airways without considering the critical development of alveoli and vascularization. This overlooks the primary function of the lungs, which is gas exchange, and the fact that airway development alone does not guarantee adequate respiratory function. This failure to consider the complete picture of lung maturation can lead to an underestimation of respiratory distress risk and delayed or inappropriate interventions. Another incorrect approach would be to assume that surfactant production is a constant and sufficient process from early gestation. This ignores the fact that surfactant synthesis is a dynamic process that matures over time, and premature infants often have insufficient levels. Relying on this assumption could lead to a lack of proactive surfactant replacement therapy when it is medically necessary, violating the standard of care. A further incorrect approach would be to disregard the impact of external factors on lung growth. While the question focuses on intrinsic developmental stages, clinical practice requires acknowledging how conditions like maternal health, placental function, and exposure to infections can influence lung development. Ignoring these external influences can lead to a generalized and less personalized approach to respiratory care. The professional decision-making process for similar situations should involve a comprehensive review of the patient's gestational age and any known risk factors for impaired lung development. This should be followed by an application of knowledge regarding the embryological stages of lung development, including alveolarization, vascular growth, and surfactant production. Clinicians must then correlate this developmental understanding with the patient's clinical presentation to determine the most appropriate respiratory support and therapeutic interventions, always adhering to established guidelines and ethical principles. Question 3. What factors determine the degree of airway resistance in a neonate or pediatric patient experiencing respiratory distress, and how do these factors influence the work of breathing? Option A. The interplay of airway caliber, airflow velocity, and the presence of inflammatory exudates or bronchoconstriction. Option B. The duration of mechanical ventilation and the type of endotracheal tube used. Option C. The patient's gestational age and birth weight, irrespective of other physiological parameters. Option D. The ambient temperature and humidity of the treatment environment. The correct answer is A. The interplay of airway caliber, airflow velocity, and the presence of inflammatory exudates or bronchoconstriction. Explanation: this scenario is professionally challenging because it requires a neonatal/pediatric respiratory care specialist, NPS, to integrate knowledge of airway physiology with the practical application of best practices in patient assessment and management, all within the strict confines of U.S. regulatory frameworks governing respiratory care. The complexity arises from the need to differentiate between intrinsic and extrinsic factors influencing airway resistance, and to prioritize interventions based on their potential impact on work of breathing and patient outcomes, adhering to standards of care and patient safety. The correct approach involves a comprehensive evaluation of both patient-specific factors and external influences that contribute to increased airway resistance. This includes assessing the patient's clinical presentation, e.g., tachypnea, retractions, accessory muscle use, auscultating breath sounds for wheezing or stridor, and considering the underlying pathology, e.g., inflammation, bronchoconstriction, secretions. This aligns with the U.S. regulatory framework, which emphasizes evidence-based practice and the delivery of safe and effective respiratory care. Professional guidelines, such as those from the American Association for Respiratory Care (ARC), underscore the importance of a systematic approach to airway management and the recognition of factors that compromise respiratory function. The NPS's responsibility is to identify and address these factors to minimize the work of breathing and improve gas exchange, thereby upholding the standard of care mandated by regulatory bodies like the Centers for Medicare and Medicaid Services, CMS, and state licensing boards. An incorrect approach would be to focus solely on one aspect of airway resistance, such as only considering bronchoconstriction, while neglecting other significant contributors like excessive secretions or dynamic airway compression. Failure to conduct a thorough assessment and consider all relevant factors would violate the principle of providing comprehensive care. Another incorrect approach would be to implement interventions without a clear understanding of their physiological impact on airway resistance and work of breathing, potentially leading to iatrogenic harm. This would contraindicate the ethical obligation to do no harm and the regulatory requirement for competent practice. Furthermore, relying on anecdotal evidence or personal preference rather than established best practices and regulatory guidelines would represent a significant professional and ethical lapse, as it deviates from the evidence-based approach required for patient safety and quality care. The professional reasoning process for similar situations should involve a systematic assessment that begins with identifying the patient's chief respiratory complaint and vital signs. This should be followed by a detailed physical examination, including auscultation and observation of respiratory effort. The NPS must then synthesize this information with the patient's medical history and current condition to identify potential causes of increased airway resistance. Interventions should be selected based on their efficacy in addressing the identified causes, with a constant reevaluation of the patient's response. This iterative process ensures that care is tailored to the individual patient's needs and remains aligned with current best practices and regulatory mandates for respiratory care in the U.S. Question 4. Governance review demonstrates a need to optimize the management of apnea of prematurity in the neonatal intensive care unit. A premature infant, born at 28 weeks gestation, is experiencing recurrent apneic episodes characterized by pauses in breathing lasting longer than 15 seconds, often accompanied by bradycardia and oxygen desaturation. The infant has been receiving routine care, including tactile stimulation for apneic spells. Which of the following approaches represents the most appropriate and evidence-based strategy for managing this infant's apnea of prematurity, considering U.S. regulatory frameworks and established neonatal respiratory care guidelines? Option A. Initiate non-invasive positive pressure ventilation, NIP, to provide consistent respiratory support and reduce the frequency and severity of apneic episodes. Option B. Continue with tactile stimulation as the primary intervention, as it is a standard practice for managing mild apneic spells. Option C. Increase the fraction of inspired oxygen, FiO2, to maintain adequate oxygen saturation, assuming the apnea is primarily hypoxemic in nature. Option D. Consider initiating caffeine citrate therapy to stimulate respiratory drive, given the infant's gestational age and the pattern of apneic episodes. The correct answer is A. Initiate non-invasive positive pressure ventilation, NIP, to provide consistent respiratory support and reduce the frequency and severity of apneic episodes. Explanation: scenario analysis. This scenario presents a common yet critical challenge in neonatal respiratory care, managing apnea of prematurity. The professional challenge lies in accurately assessing the underlying cause of apnea and implementing an appropriate, evidence-based intervention that balances efficacy with potential risks, all while adhering to established clinical guidelines and regulatory standards for neonatal care. The need for careful judgment stems from the delicate physiological state of premature infants and the potential for respiratory compromise to lead to significant morbidity and mortality. Correct approach analysis. The correct approach involves a comprehensive assessment of the infant's clinical status, including gestational age, weight, and the pattern of apneic episodes. This assessment should then guide the selection of an intervention that directly addresses the physiological mechanisms of apnea of prematurity, such as impaired respiratory drive or upper airway collapse. In the context of U.S. regulations for neonatal care, this aligns with the principles of evidence-based practice and patient safety, mandated by bodies like the Joint Commission and the American Academy of Pediatrics (OP) guidelines. Specifically, interventions like non-invasive positive pressure ventilation, NIPV, or pharmacologic agents e.g. caffeine citrate are supported by extensive research and are considered standard of care for moderate to severe apnea of prematurity when indicated by clinical assessment. The decision to use such interventions must be documented and justified based on the infant's specific needs and response. Incorrect approaches analysis. Implementing continuous positive airway pressure, CPAP, without a thorough assessment of the infant's specific apneic pattern and underlying physiological cause is an incorrect approach. While CPAP can be beneficial, it may not be the most appropriate first-line intervention for all types of apnea, and could potentially mask or exacerbate certain issues if not indicated. This deviates from the principle of individualized care and evidence-based decision-making. Initiating mechanical ventilation immediately for any apneic episode without first exploring less invasive and more targeted therapies is also an incorrect approach. This overintervention carries increased risks of ventilator-associated complications and may not be necessary if the apnea can be managed with other modalities. It fails to adhere to the principle of using the least restrictive intervention necessary. Administering respiratory stimulants without a clear indication of central hypoventilation as the primary driver of apnea, or without considering the infant's gestational age and potential side effects, is an incorrect approach. This demonstrates a lack of understanding of the specific pathophysiology of apnea of prematurity and a failure to apply evidence-based guidelines, potentially leading to adverse outcomes. Professional reasoning. Professionals should employ a systematic approach to managing apnea of prematurity. This involves 1. Initial assessment of the infant's vital signs, gestational age, and the characteristics of the apneic episodes, e.g. central, obstructive, mixed. 2. Review of current clinical practice guidelines from reputable organizations like the AAP. 3. Consideration of the least invasive, most effective intervention based on the assessment and guidelines. 4. Close monitoring of the infant's response to intervention and adjustment of the treatment plan as needed. Documentation of the assessment, rationale for intervention, and response is crucial for regulatory compliance and continuity of care. Question 5. The assessment process reveals a neonate with tachypnea and grunting, and the following blood gas analysis, pH 7, 28, PA CO 255 mmHg, HCO 3-24 mx/L. Which of the following interpretations best reflects the likely acid-base status and compensatory mechanism? Option A. Uncompensated respiratory acidosis with no significant metabolic compensation. Option B. Partially compensated respiratory acidosis with a primary increase in carbon dioxide. Option C. Uncompensated metabolic acidosis with a primary decrease in bicarbonate. Option D. Partially compensated metabolic alkalosis with a primary increase in bicarbonate. The correct answer is A. Uncompensated respiratory acidosis with no significant metabolic compensation. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in neonatal/pediatric respiratory care, interpreting complex acid-base disturbances in a critically ill infant. The professional challenge lies in accurately diagnosing the underlying acid-base imbalance and its compensatory mechanisms, which directly impacts the selection of appropriate respiratory support and therapeutic interventions. Failure to correctly interpret blood gas analysis can lead to delayed or incorrect treatment, potentially resulting in significant morbidity or mortality. The rapid physiological changes in neonates and pediatric patients necessitate prompt and precise clinical judgment, guided by established protocols and evidence-based practice. Correct approach analysis. The correct approach involves a systematic interpretation of the blood gas parameters, focusing on the primary disorder pH, PaCO2, HCO3, the compensatory response, and the oxygenation status. This aligns with the core competencies expected of a neonatal/pediatric respiratory care specialist as defined by professional standards and regulatory guidelines. Specifically, understanding the interplay between PaCO2 and HCO3 in relation to pH is crucial for identifying respiratory versus metabolic origins of the imbalance and assessing the body's compensatory efforts. This systematic approach ensures that interventions are targeted and effective, adhering to the principle of providing appropriate and evidence-based care. Incorrect approaches analysis. Focusing solely on the pH value without considering the PaCO2 and HCO3 is a significant regulatory and ethical failure. Professional guidelines mandate a comprehensive interpretation of all blood gas parameters to accurately diagnose the acid-base disturbance. Ignoring the PaCO2 or HCO3 can lead to misdiagnosis, such as mistaking a compensated metabolic acidosis for a primary respiratory acidosis, resulting in inappropriate management. Attributing the acid-base imbalance solely to the patient's gestational age without a thorough blood gas analysis is also professionally unacceptable. Gestational age is a significant factor influencing neonatal physiology. It does not replace the need for objective data from blood gas analysis to confirm and quantify an acid-base disturbance. This approach bypasses essential diagnostic steps and could lead to overlooking critical underlying issues. Interpreting the blood gas results based on anecdotal experience or the most recent case encountered, rather than a systematic, evidence-based approach, represents a failure to adhere to professional standards of care. Regulatory frameworks emphasize the importance of standardized interpretation protocols to ensure consistent and high-quality patient care. Relying on subjective experience over objective data and established protocols can lead to biased interpretations and suboptimal patient outcomes. Professional reasoning. Professionals should approach blood gas interpretation by first assessing the pH to determine if the patient is in acidosis or alkalosis. Next, they should examine the PaCO2 to identify a primary respiratory disturbance or a compensatory response. Subsequently, the HCO3 level is evaluated to determine if a primary metabolic disturbance or a compensatory response is present. Finally, all three values are integrated to identify the primary acid-base disorder and the degree of compensation. This systematic process, grounded in established physiological principles and regulatory expectations for respiratory care specialists, ensures accurate diagnosis and guides appropriate therapeutic interventions. Question 6. Process analysis reveals that a neonate presents with increasing cyanosis, tachypnea, and signs of circulatory compromise, despite initial supportive measures. The clinical team suspects persistent pulmonary hypertension of the newborn, PPHN. Which of the following approaches best reflects the initial management strategy for this critically ill neonate, considering the factors affecting pulmonary vascular resistance, PVR? Option A. Immediately initiate inhaled nitric oxide therapy and consider systemic vasodilators to reduce PVR. Option B. Prioritize optimizing systemic oxygenation and ventilation while assessing and correcting acid-base balance. Option C. Increase the fraction of inspired oxygen, FiO2, to 100% and await spontaneous improvement in PVR. Option D. Focus on aggressive fluid resuscitation to improve systemic perfusion, assuming PPHN is secondary to hypovolemia. Correct answer is A. Immediately initiate inhaled nitric oxide therapy and consider systemic vasodilators to reduce PVR. Explanation. Scenario analysis. This scenario is professionally challenging because it requires a neonatal/pediatric respiratory care specialist, NPS, to interpret complex physiological data in the context of a critically ill neonate with suspected persistent pulmonary hypertension of the newborn, PPHN. The rapid deterioration of the infant's condition necessitates swift and accurate assessment of pulmonary vascular resistance, PVR, and its contributing factors to guide appropriate therapeutic interventions. Failure to correctly identify the underlying cause and impact of elevated PVR can lead to delayed or inappropriate treatment, potentially resulting in irreversible organ damage or mortality. The NPS must integrate knowledge of neonatal physiology, PPHN pathophysiology, and current clinical guidelines to make informed decisions. Correct approach analysis. The correct approach involves a comprehensive assessment of factors influencing PVR in the neonate, including systemic oxygenation, ventilation, acid-base balance, temperature, and circulating vasoactive substances. This aligns with the established understanding of PPHN pathophysiology, where increased PVR impedes the transition from fetal to neonatal circulation. Specifically, the approach that prioritizes evaluating and optimizing oxygenation and ventilation directly addresses the most common and reversible causes of increased PVR in neonates. Maintaining adequate systemic oxygenation is crucial, as hypoxemia causes pulmonary vasoconstriction. Similarly, appropriate ventilation helps to maintain lung volume and reduce alveolar hypoxia, both of which contribute to lower PVR. This systematic evaluation is supported by clinical practice guidelines for neonatal respiratory care, which emphasize a stepwise approach to managing PPHN by addressing reversible factors before considering more invasive therapies. Incorrect approaches analysis. An approach that solely focuses on administering vasodilators without first optimizing oxygenation and ventilation is incorrect. This fails to address the primary drivers of increased PVR in many PPHN cases and could mask underlying issues, leading to a delay in effective treatment. Furthermore, administering vasodilators without adequate physiological support can lead to systemic hypotension, which is detrimental to the neonate. An approach that neglects to assess and correct acid-base disturbances is also incorrect. Acidosis, particularly respiratory acidosis, is a potent stimulus for pulmonary vasoconstriction and can significantly exacerbate PPHN. Failing to address this fundamental physiological derangement will hinder efforts to reduce PVR. An approach that prioritizes mechanical ventilation settings without considering the underlying cause of PPHN and the specific hemodynamic profile of the infant is incomplete. While ventilation is critical, the optimal settings are dependent on the infant's response and the specific etiology of PPHN. A rigid approach without dynamic assessment and adjustment is not evidence-based. Professional reasoning. Professionals should employ a systematic, evidence-based approach to managing PPHN. This involves a thorough initial assessment of the neonate's respiratory and hemodynamic status, followed by a stepwise intervention strategy. The framework should include 1. Ensuring adequate systemic oxygenation and ventilation. 2. Correcting acid-base and metabolic derangements. 3. Considering pharmacologic interventions, e.g., inhaled nitric oxide, vasodilators, based on the infant's response and specific clinical presentation. And 4. Continuous monitoring and reassessment. This iterative process allows for tailored management and adaptation to the infant's evolving condition, adhering to best practices in neonatal respiratory care. Question 7. Quality control measures reveal a 3-day-old neonate presenting with persistent tachypnea, respiratory rate 70 breaths/min, mild subcostal retractions, and occasional grunting. The infant was born via elective cesarean section at 39 weeks gestation. A chest X-ray shows bilateral perihilar streaking and mild hyperinflation. Which of the following diagnostic and management strategies is most appropriate for this neonate? Option A. Administer supplemental oxygen via nasal cannula to maintain SpO2 between 90–95%. Initiate continuous positive airway pressure, CPAP, if oxygen requirements exceed 40%, and closely monitor for improvement over the next 24–48 hours. Option B. Discharge the infant home with close-out patient follow-up, as tachypnea in a term infant after cesarean section is typically self-limiting and requires no intervention. Option C. Obtain a complete blood count, CBC, and blood gas analysis to rule out sepsis and metabolic acidosis, and consider empiric antibiotic therapy. Option D. Immediately initiate mechanical ventilation with a tidal volume of 6 ml/kg and a positive end expiratory pressure (PEEP) of 8 cm H2O to ensure adequate gas exchange. The correct answer is A. Administer supplemental oxygen via nasal cannula to maintain SpO2 between 90–95%. Initiate continuous positive airway pressure, CPAP, if oxygen requirements exceed 40%, and closely monitor for improvement over the next 24–48 hours. Explanation: this scenario presents a common clinical challenge in neonatal respiratory care, differentiating transient tachypnea of the newborn, TTN, from other, potentially more serious respiratory conditions. The professional challenge lies in the overlapping clinical presentations and the need for timely and accurate diagnosis to ensure appropriate management and prevent adverse outcomes. Misdiagnosis can lead to delayed or unnecessary interventions, impacting patient safety and resource utilization. Careful judgment is required to interpret clinical signs, radiographic findings, and response to treatment within the established guidelines for neonatal respiratory distress. The correct approach involves a systematic evaluation that begins with a thorough history and physical examination, focusing on risk factors for TTN, e.g., cesarean section delivery, maternal diabetes, prematurity. This is followed by appropriate diagnostic imaging, typically a chest X-ray, to assess for characteristic findings of TTN such as fluid in the interlobar fissures, perihilar streaking, and hyperinflation. Management should then be initiated based on the clinical presentation and diagnostic findings, prioritizing supportive care such as supplemental oxygen and, if necessary, non-invasive ventilation, while closely monitoring the infant's response. This approach aligns with established clinical practice guidelines and regulatory frameworks for neonatal respiratory care, emphasizing evidence-based management and patient safety. The focus is on identifying TTN and providing appropriate supportive care, avoiding invasive interventions unless indicated. An incorrect approach would be to immediately initiate aggressive mechanical ventilation without a thorough diagnostic workup. This fails to adhere to the principle of least invasive intervention and can lead to complications associated with mechanical ventilation in neonates, such as pneumothorax or ventilator-induced lung injury. Another incorrect approach would be to dismiss the tachypnea as benign without further investigation, potentially delaying diagnosis and treatment of a more serious underlying condition. This neglects the professional responsibility to thoroughly assess and manage neonatal respiratory distress. A third incorrect approach would be to rely solely on clinical presentation without corroborating diagnostic imaging, which can lead to misinterpretation of the underlying pathology. Professionals should employ a structured decision-making process that includes 1. Comprehensive assessment of the infant's clinical status and risk factors. 2. Utilization of diagnostic tools, e.g., chest X-ray, to confirm or refute suspected diagnoses. 3. Initiation of management based on established protocols and evidence-based practice. And 4. Continuous reassessment of the infant's response to treatment, adjusting the care plan as needed. This systematic approach ensures that management is tailored to the specific needs of the neonate and adheres to the highest standards of care. Question 8. Stakeholder feedback indicates a need to refine our approach to managing hypoxemia in neonates with suspected congenital diaphragmatic hernia. Given the known challenges with ventilation perfusion, V/Q, matching and diffusion limitations in these infants, which of the following strategies best reflects a comprehensive approach to optimizing gas exchange, considering the impact on oxygen transport and carbon dioxide elimination? Option A. Increasing positive end expiratory pressure, PEEP, to maximal levels to recruit alveoli and improve oxygenation without significant consideration for potential overdistension or impaired venous return. Option B. Focusing solely on increasing the respiratory rate on mechanical ventilation to reduce carbon dioxide retention without a concurrent evaluation of oxygenation or the underlying causes of the hypoxemia. Option C. Implementing a strategy that involves a thorough assessment of the neonate's current ventilation and perfusion status, utilizing blood gas analysis and imaging to guide adjustments in ventilatory support and oxygen therapy to achieve optimal V/Q matching and facilitate efficient diffusion. Option D. Administering high concentrations of supplemental oxygen to rapidly improve arterial oxygen saturation, while closely monitoring for signs of hyperoxia. Correct answer is D. Administering high concentrations of supplemental oxygen to rapidly improve arterial oxygen saturation, while closely monitoring for signs of hyperoxia. Explanation: scenario analysis. This scenario is professionally challenging because it requires the respiratory therapist to interpret complex physiological data in the context of a critically ill neonate, balancing immediate clinical needs with long-term developmental outcomes. The pressure to make rapid, accurate decisions regarding gas exchange management, especially when faced with conflicting data or limited resources, necessitates a deep understanding of the underlying pathophysiology and relevant regulatory guidelines. The challenge lies in synthesizing information about diffusion, V/Q matching, and oxygen/carbon dioxide transport to optimize respiratory support without causing iatrogenic harm. Correct approach analysis. The correct approach involves a systematic evaluation of the neonate's clinical presentation, including vital signs, blood gas analysis, and chest X-ray findings, to identify the primary drivers of impaired gas exchange. This approach prioritizes understanding the interplay between alveolar ventilation and pulmonary perfusion, recognizing that imbalances in V/Q matching are common in neonates due to immature lung structures and potential congenital anomalies. The therapist must then apply knowledge of the alveolar gas equation to interpret the partial pressures of oxygen and carbon dioxide, considering factors affecting diffusion such as alveolar capillary membrane thickness and surfactant production. The ultimate goal is to tailor respiratory support, whether it be supplemental oxygen, mechanical ventilation settings, or other interventions, to improve oxygenation and ventilation while minimizing risks like barotrauma or oxygen toxicity, all within the established standards of care for neonatal respiratory therapy. This aligns with the overarching ethical and regulatory mandate to provide safe, effective, and evidence-based care to vulnerable pediatric populations. Incorrect approaches analysis, an approach that solely focuses on increasing the fraction of inspired oxygen, FiO2, without a thorough assessment of ventilation-perfusion matching or potential diffusion limitations, fails to address the root cause of the gas exchange abnormality. This can lead to hyperoxia, which carries its own risks in neonates, and may mask underlying issues that require different interventions. This approach neglects the comprehensive understanding of gas exchange principles mandated by professional practice, an approach that prioritizes aggressive mechanical ventilation setting to normalize blood gas values without considering the impact on alveolar capillary membrane stress or the potential for worsening V/Q mismatch, is also problematic. While achieving target blood gas values is important, the method used can have significant adverse consequences, such as pneumothorax or chronic lung disease, which are contrary to the principles of minimizing harm and promoting optimal development. This overlooks the delicate balance required in neonatal respiratory support, an approach that relies on empirical adjustments to ventilator parameters based on anecdotal experience, rather than a systematic analysis of the patient's physiological response and the underlying principles of gas exchange, demonstrates a failure to adhere to evidence-based practice and professional standards. This can lead to suboptimal or even detrimental care, as it bypasses the critical thinking required to diagnose and manage complex respiratory conditions in neonates. Professional reasoning. Respiratory therapists caring for neonates must employ a structured problem-solving approach. This begins with a thorough assessment of the patient's current status, integrating clinical signs, symptoms, and diagnostic data. Next, they must identify the specific gas exchange abnormality, e.g., hypoxemia, hypercapnia, and hypothesize the underlying physiological cause, considering factors affecting diffusion, V/Q matching, and transport. This hypothesis is then tested by evaluating the patient's response to interventions and further diagnostic data. Throughout this process, adherence to established clinical practice guidelines, ethical principles of beneficence and non-maleficence, and relevant regulatory frameworks governing pediatric respiratory care is paramount. Continuous reassessment and adaptation of the treatment plan based on ongoing evaluation are essential for optimizing outcomes. Question 9. Market research demonstrates a growing need for specialized respiratory care in neonatal intensive care units. A 3-day-old infant born at 28 weeks gestation is receiving mechanical ventilation for respiratory distress syndrome. The infant's current arterial blood gas, AB, reveals a PaO2 of 55 mmHg, PaCO2 of 40 mmHg, and pH of 7.35, with a FiO2 of 0.6 and PEEP of 8 cmH2O. The infant's minute ventilation is adequate for their size. Based on these findings and the principles of gas exchange, Which of the following diagnostic and therapeutic considerations is most appropriate for the neonatal/pediatric respiratory care specialist, NPS, to pursue next? Option A. Administer a surfactant bolus and reassess ABGs in 30 minutes. Option B. Initiate inhaled nitric oxide therapy to improve pulmonary vasodilation. Option C. Evaluate for intrapulmonary shunting and consider increasing PEEP or implementing recruitment maneuvers. Option D. Increase the FiO2 to 0.8 and monitor for improvement in PaO2. The correct answer is D. Increase the FiO2 to 0.8 and monitor for improvement in PaO2. Explanation. This scenario is professionally challenging because it requires the neonatal/pediatric respiratory care specialist, NPS, to interpret complex physiological data in the context of a critically ill infant, where timely and accurate assessment directly impacts patient outcomes and adherence to established clinical guidelines. The challenge lies in differentiating between a primary ventilation issue and a diffusion limitation, both of which can manifest with similar signs of hypoxemia. The NPS must apply their knowledge of gas exchange principles and the specific regulatory framework governing their practice to make an informed decision. The correct approach involves a systematic evaluation of ventilation and perfusion parameters, followed by an assessment of diffusion capacity. This begins with analyzing the arterial blood gas, ABG results, specifically the partial pressure of oxygen, PaO2, and partial pressure of carbon dioxide, PaCO2, in conjunction with the patient's minute ventilation. If the PaCO2 is elevated despite adequate or increased minute ventilation, it suggests a ventilation perfusion, V/Q, mismatch or intrapulmonary shunting, pointing towards a ventilation issue. Conversely, if the PaCO2 is normal or low with adequate ventilation, and the PaO2 remains low, it strongly suggests a diffusion limitation or significant shunt. The NPS would then consider further diagnostic steps, such as a trial of increased FiO2 or positive end expiratory pressure, PEEP, to assess the patient's response and guide therapy. This aligns with the NPS scope of practice, which mandates evidence-based care and adherence to established protocols for respiratory management in neonates and pediatrics, as outlined by relevant professional organizations and regulatory bodies that define standards of care. An incorrect approach would be to solely focus on increasing the fraction of inspired oxygen, FiO2, without a thorough assessment of ventilation and perfusion. This fails to address the underlying cause of hypoxemia if it is primarily a ventilation problem. It also risks oxygen toxicity and can mask a worsening V/Q mismatch, leading to delayed appropriate interventions. Another incorrect approach would be to immediately assume a diffusion limitation and initiate therapies like high-frequency oscillatory ventilation, HFOV, without first ruling out more common causes of hypoxemia, such as inadequate ventilation or significant intrapulmonary shunting. This premature escalation of therapy can be resource-intensive and may not be the most effective treatment for the patient's condition. A third incorrect approach would be to disregard the ABG findings and rely solely on pulse oximetry, which can be unreliable in certain clinical situations and does not provide information on carbon dioxide levels, a crucial indicator of ventilation status. This overlooks critical data necessary for accurate diagnosis and treatment planning, potentially violating professional standards of care that emphasize comprehensive patient assessment. Professional reasoning in such situations requires a structured approach. First, gather all available clinical data, vital signs, ventilator settings, ABG, chest X-ray. Second, analyze the data using established physiological principles of gas exchange. Third, formulate a differential diagnosis based on the findings. Fourth, consult relevant clinical guidelines and protocols. Fifth, develop a treatment plan that addresses the most likely cause while remaining adaptable to the patient's response. Finally, continuously reassess the patient and adjust the plan as needed. Question 10. The monitoring system demonstrates recurrent apneic episodes in a 28-week gestational age neonate, with each episode lasting approximately 15-20 seconds and associated with transient desaturations to 88% and mild bradycardia. The neonate is currently receiving nasal CPAP at 5 cm H2O. Which of the following management strategies is most appropriate for this clinical presentation? Option A, transition to mechanical ventilation immediately. Option B, initiate caffeine citrate therapy and continue nasal CPAP. Option C, increase tactile stimulation to prevent apneic pauses. Option D, Observe and document the episodes without intervention. The correct answer is B. Initiate caffeine citrate therapy and continue nasal CPAP. Explanation. This scenario presents a common yet critical challenge in neonatal respiratory care, managing apnea of prematurity in a neonate exhibiting recurrent episodes. The professional challenge lies in accurately assessing the severity and pattern of apnea, differentiating it from other potential causes of respiratory compromise, and initiating appropriate, evidence-based management while adhering to established clinical guidelines and regulatory standards for neonatal care. The neonate's gestational age and clinical presentation are key factors influencing the diagnostic and therapeutic approach. The correct approach involves a comprehensive assessment of the apneic events, including their frequency, duration, and associated clinical signs, e.g., bradycardia, desaturation. This assessment informs the decision to initiate pharmacologic therapy with caffeine citrate, a first-line treatment for apnea of prematurity. Caffeine citrate is indicated to stimulate the central nervous system and reduce the frequency and severity of apneic spells. Concurrently, non-invasive ventilatory support, such as continuous positive airway pressure, CPAP, is often employed to maintain airway patency and prevent alveolar collapse, thereby reducing the likelihood of apneic episodes. This combined approach is supported by numerous clinical guidelines and regulatory frameworks governing neonatal respiratory care, emphasizing evidence-based practice and patient safety. An incorrect approach would be to solely rely on increased tactile stimulation to manage the apneic episodes. While tactile stimulation can sometimes transiently resolve a brief apneic pause, it is not a sustained or evidence-based treatment for significant apnea of prematurity. Failure to initiate appropriate pharmacologic and ventilatory support can lead to prolonged hypoxemia, bradycardia, and potential long-term neurodevelopmental sequelae, representing a failure to meet the standard of care and potentially violating regulatory requirements for adequate patient management. Another incorrect approach would be to immediately escalate to mechanical ventilation without a thorough trial of caffeine and CPAP. Mechanical ventilation carries inherent risks and should be reserved for cases where less invasive measures have failed or are contraindicated. Prematurely initiating mechanical ventilation without exhausting less invasive options is not aligned with current best practices and may expose the neonate to unnecessary risks. A third incorrect approach would be to disregard the apneic episodes as a normal consequence of prematurity and to withhold any intervention. This passive approach fails to recognize the potential morbidity associated with untreated apnea of prematurity and is a clear deviation from the expected standard of care, potentially leading to adverse patient outcomes and regulatory scrutiny. The professional decision-making process for similar situations should involve a systematic evaluation of the neonate's clinical status, a thorough understanding of the pathophysiology of apnea of prematurity, and the application of evidence-based treatment guidelines. This includes continuous monitoring, accurate documentation, timely initiation of appropriate therapies, pharmacologic and ventilatory support, and ongoing reassessment of the patient's response to treatment. Collaboration with the neonatology team is crucial in ensuring optimal patient care. Question 11. Market research demonstrates that a significant portion of pediatric asthma diagnoses are initially made based on symptom presentation alone. A 7-year-old child presents with recurrent episodes of wheezing, cough, and shortness of breath, particularly at night and with exercise. The NPS is tasked with developing an optimal diagnostic and management strategy. Which of the following approaches best aligns with the regulatory framework for neonatal/pediatric respiratory care specialists in ensuring accurate diagnosis and effective long-term management of pediatric asthma? Option A. Initiate a trial of inhaled corticosteroids and bronchodilators based on reported symptoms, and schedule a follow-up appointment in 3 months to assess response. Option B. Conduct a thorough physical examination, obtain a detailed history of symptoms and potential triggers, and perform spirometry and peak expiratory flow rate (PEFR) measurements to establish a definitive diagnosis and assess severity before initiating a comprehensive asthma action plan. Option C. Prescribe a short course of oral corticosteroids to quickly resolve current symptoms and advise the family to seek further evaluation if symptoms recur. Option D. Rely on the parent's description of the child's symptoms to determine the appropriate medication dosage and frequency without further objective testing. The correct answer is A. Initiate a trial of inhaled corticosteroids in bronchodilators based on reported symptoms, and schedule a follow-up appointment in 3 months to assess response. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the Neonatal/Pediatric Respiratory Care Specialist, NPS, to interpret complex clinical data and apply it to a patient with a chronic, potentially life-threatening condition. The NPS must balance immediate symptom relief with long-term management strategies, considering the unique physiological differences in pediatric patients. Accurate diagnosis and management are critical to prevent exacerbations, improve quality of life, and avoid long-term respiratory sequelae, all while adhering to established clinical guidelines and regulatory frameworks. Correct approach analysis. The correct approach involves a comprehensive assessment that integrates patient history, physical examination findings, and objective diagnostic data, specifically spirometry and peak expiratory, flow rate, PEFR measurements, to establish a definitive diagnosis and severity of asthma. This aligns with the regulatory framework for respiratory care specialists, which mandates evidence-based practice and adherence to established diagnostic criteria. The subsequent development of a personalized asthma action plan, incorporating appropriate pharmacotherapy and trigger avoidance strategies, is crucial for effective management and patient safety. This systematic, data-driven approach ensures that interventions are tailored to the individual child's needs and are consistent with best practices for pediatric asthma care, as outlined by relevant professional bodies and regulatory oversight. Incorrect approach is analysis, an approach that relies solely on subjective symptom reporting without objective diagnostic testing fails to meet the diagnostic rigor required by regulatory standards. This can lead to misdiagnosis or underestimation of disease severity, potentially resulting in delayed or inadequate treatment. An approach that focuses only on bronchodilator therapy without addressing underlying inflammation or developing a comprehensive action plan neglects the chronic nature of asthma and the importance of long-term control. This is a failure to provide holistic care as expected within the scope of practice. An approach that disregards potential environmental or other triggers or fails to educate the patient and family on their avoidance is incomplete. Effective asthma management requires a multifaceted strategy that includes trigger identification and mitigation, which is a standard expectation for respiratory care specialists. Professional reasoning. Professionals should employ a systematic diagnostic and management process. This begins with a thorough patient history and physical examination, followed by objective diagnostic testing spirometry, PEFR, to confirm the diagnosis and assess severity. Based on these findings, a personalized treatment plan should be developed, incorporating pharmacotherapy, trigger avoidance, and a clear asthma action plan. Continuous monitoring and regular reassessment are essential to adjust the plan as needed, ensuring optimal patient outcomes and adherence to professional and regulatory standards. Question 12. The control framework reveals that a neonate, born at 39 weeks gestation via spontaneous vaginal delivery, exhibits mild tachypnea and transient cyanosis of the extremities in the first minute of life. Auscultation reveals a regular heart rhythm with no murmurs. The infant is crying vigorously and has good muscle tone. Based on the expected physiological transition from fetal to newborn circulation, which of the following interpretations of these findings is most consistent with normal adaptation? Option A. The findings are indicative of a significant intracardiac shunt requiring urgent echocardiographic evaluation and potential surgical intervention. Option B. The findings necessitate aggressive fluid resuscitation and inotropic support to manage presumed hypoperfusion and low systemic vascular resistance. Option C. The findings suggest the need for immediate mechanical ventilation and pharmacological closure of the ductus arteriosus due to persistent fetal circulation. Option D. The findings are consistent with the normal physiological closure of the ductus arteriosus and foramen ovale, driven by increased systemic vascular resistance and decreased pulmonary vascular resistance. The correct answer is C. The findings suggest the need for immediate mechanical ventilation and pharmacological closure of the ductus arteriosus due to persistent fetal circulation. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the clinician to interpret subtle physiological changes in a neonate immediately after birth and correlate them with the expected transition from fetal to newborn circulation. Misinterpreting these signs can lead to delayed or inappropriate interventions, potentially impacting the infant's oxygenation and hemodynamics. The pressure to act quickly in a dynamic environment, while adhering to established protocols and understanding complex physiological shifts, demands precise clinical judgment. Correct approach analysis. The correct approach involves recognizing that the observed findings are consistent with the normal physiological closure of the ductus arteriosus and foramen ovale, driven by changes in pressure gradients and oxygenation. The decrease in pulmonary vascular resistance, PVR, and increase in systemic vascular resistance, SVR, are expected events. This understanding allows the clinician to anticipate the infant's needs and provide supportive care without unnecessary alarm or intervention, aligning with the principle of first, do no harm, and evidence-based practice for neonatal resuscitation and transition. Incorrect approaches analysis. An approach that immediately initiates aggressive pharmacological intervention to constrict the ductus arteriosus or alter pulmonary pressures without clear evidence of pathology fails to acknowledge the normal physiological transition. This could lead to iatrogenic complications, such as excessive systemic hypertension or impaired venous return, and deviates from the principle of minimizing unnecessary medical interventions. An approach that focuses solely on increasing supplemental oxygen without assessing the underlying hemodynamic status or considering the role of PVR and SVR changes is incomplete. Oxygen is crucial. It is one component of the transition. Ignoring the dynamic vascular resistance shifts could mask or exacerbate other issues. An approach that assumes the infant is experiencing significant congenital heart disease or persistent pulmonary hypertension of the newborn based on these initial, transient findings is premature. This could lead to unnecessary diagnostic workups and interventions that cause stress to the infant and family and are not supported by the initial clinical picture. Professional reasoning. Professionals should approach this situation by first performing a thorough assessment of the neonate's respiratory effort, heart rate, color, and tone. They should then consider the expected physiological changes at birth, specifically the closure mechanisms of the ductus arteriosus and foramen ovale, and the reciprocal changes in PVR and SVR. This understanding guides the decision-making process. Observe and support normal transition, or intervene if signs of distress or pathology are evident. Continuous monitoring and reassessment are key to differentiating normal adaptation from complications. Question 13. Compliance review shows a neonate presenting with sudden onset of severe respiratory distress, decreased breath sounds on one side, and subcutaneous emphysema. The neonate's condition is rapidly deteriorating, with increasing oxygen requirements and signs of hemodynamic instability. Based on the Neonatal/Pediatric Respiratory Care Specialist, NPS, regulatory framework, which of the following actions best represent the appropriate management of this emergent situation, considering both patient care and regulatory compliance? Option A. Administer a higher concentration of oxygen and increase positive pressure ventilation, anticipating that these measures will resolve the respiratory distress without the need for invasive procedures. Option B. Immediately initiate chest tube insertion to relieve the suspected pneumothorax and pneumomediastinum, while simultaneously attempting to obtain informed consent from the parents by providing a concise explanation of the procedure, its necessity, risks, benefits, and alternatives, and documenting these efforts. Option C. Proceed with chest tube insertion without any attempt to inform or involve the parents, as the emergent nature of the situation supersedes any need for consent. Option D. Delay chest tube insertion until a full, detailed, informed consent discussion can be completed with the parents, ensuring all their questions are answered thoroughly before proceeding. The correct answer is B. Immediately initiate chest tube insertion to relieve the suspected pneumothorax and pneumomediastinum, while simultaneously attempting to obtain informed consent from the parents by providing a concise explanation of the procedure, its necessity, risks, benefits, and alternatives, and documenting these efforts. Explanation. This scenario is professionally challenging because it requires immediate and decisive action in a critical care setting, balancing the urgency of a potentially life-threatening condition with adherence to established protocols and the need for informed consent, even in emergent situations. The neonate's condition is rapidly deteriorating, necessitating swift intervention to stabilize their respiratory status. The core challenge lies in navigating the ethical and regulatory imperative to provide life-saving treatment while respecting parental rights and ensuring appropriate documentation. The correct approach involves recognizing the signs and symptoms of pneumothorax and pneumomediastinum, initiating appropriate diagnostic measures, and proceeding with chest tube insertion as a life-saving intervention, while simultaneously attempting to obtain informed consent from the parents or legal guardians. This aligns with the regulatory framework governing neonatal and pediatric respiratory care, which prioritizes patient well-being and the provision of necessary medical interventions. Specifically, guidelines emphasize the importance of prompt diagnosis and management of respiratory emergencies. Ethically, the principle of beneficence dictates that healthcare providers must act in the best interest of the patient, which in this case is to relieve the pressure on the lungs and heart caused by the air leak. The regulatory framework also mandates efforts to obtain informed consent whenever possible, even in emergencies, by providing essential information about the procedure, its risks, benefits, and alternatives, and documenting these efforts. An incorrect approach would be to delay chest tube insertion pending complete, detailed informed consent if the neonate's condition is critical and deteriorating rapidly, as this could lead to irreversible harm or death. This failure to act promptly violates the principle of beneficence and potentially the regulatory requirement to provide timely care in emergent situations. Another incorrect approach would be to proceed with chest tube insertion without any attempt to inform or involve the parents, even if the situation is emergent. While emergent situations may necessitate implied consent for life-saving measures, a complete disregard for parental involvement, when even brief communication is feasible, could violate ethical principles of autonomy and respect for persons, and may not fully align with regulatory expectations for documentation of emergent consent. Finally, misinterpreting the clinical presentation and opting for less invasive interventions when a pneumothorax is strongly suspected would be a critical failure, as it delays definitive treatment and could lead to adverse outcomes, contravening the regulatory mandate for appropriate diagnostic and therapeutic interventions for recognized respiratory distress. Professional decision-making in such situations requires a rapid assessment of the patient's clinical status, a thorough understanding of the pathophysiology of pneumothorax and pneumomediastinum, and a clear grasp of the regulatory and ethical guidelines for emergent interventions. It involves prioritizing immediate life-saving measures while concurrently making diligent efforts to communicate with and involve the parents or guardians, documenting all actions and communications meticulously. Question 14. System analysis indicates that a 3-day-old neonate, born at 30 weeks gestation, is presenting with intermittent episodes of bradycardia and desaturation, particularly during feeding. The neonate is currently receiving supplemental oxygen via nasal cannula at 0.5 L/min and has a heart rate of 140 BPM and a respiratory rate of 55 breaths/min. The primary challenge is to determine the most appropriate initial management strategy. Which of the following approaches best reflects an understanding of pediatric respiratory physiology and best practice for this age group? Option A. Increase the fraction of inspired oxygen, FiO2, to 100% to immediately correct the desaturation. Option B. Administer a bolus of intravenous fluid to address potential hypovolemia contributing to the bradycardia. Option C. Obtain a chest X-ray to rule out pneumonia as the primary cause of respiratory distress. Option D. Initiate continuous positive airway pressure, CPAP, via nasal prongs to support alveolar stability and reduce the work of breathing. The correct answer is D. Initiate continuous positive airway pressure, CPAP, via nasal prongs to support alveolar stability and reduce the work of breathing. Explanation. This scenario is professionally challenging due to the inherent variability in pediatric respiratory physiology and the potential for rapid deterioration in neonates and infants. The specialist must integrate knowledge of normal development with an understanding of how disease processes alter these physiological parameters. Careful judgment is required to differentiate between normal developmental variations and pathological conditions, ensuring timely and appropriate intervention. The correct approach involves a comprehensive assessment of the infant's current respiratory status, considering their gestational age, postnatal age, and clinical presentation. This includes evaluating vital signs, breath sounds, work of breathing, and oxygenation/ventilation parameters. The specialist must then correlate these findings with established pediatric respiratory physiology principles, recognizing that deviations from expected norms may indicate underlying pathology. This approach aligns with the ethical obligation to provide evidence-based care and the regulatory requirement to practice within the scope of specialized knowledge, ensuring patient safety and optimal outcomes. An incorrect approach would be to solely rely on adult-based respiratory parameters or to assume a stable condition without continuous reassessment. This fails to acknowledge the unique physiological differences in neonates and infants, such as smaller airway diameters, less developed surfactant systems, and different chest wall mechanics, which can lead to rapid decompensation. Such an approach could result in delayed or inappropriate intervention, violating the standard of care and potentially harming the patient. Another incorrect approach would be to focus exclusively on pharmacological interventions without a thorough understanding of the underlying physiological derangements. While medications are crucial, their efficacy and safety are directly tied to the patient's physiological state. Administering treatments without a clear physiological rationale, or without considering the potential impact on the infant's delicate system, represents a failure to apply specialized knowledge and could lead to adverse effects or treatment failure. A third incorrect approach would be to disregard parental concerns or observations. While the specialist possesses expert knowledge, parents are often the first to notice subtle changes in their child's behavior or breathing. Ignoring these observations can lead to missed early warning signs and a delay in critical interventions. Ethical practice mandates a collaborative approach, valuing the input of caregivers as part of the comprehensive assessment. The professional reasoning framework for similar situations should involve a systematic process. 1. Gather comprehensive patient data, history, physical exam, monitoring data. 2. Analyze the data through the lens of pediatric respiratory physiology, identifying deviations from normal. 3. Formulate differential diagnoses based on the physiological derangements. 4. Develop an evidence-based management plan, prioritizing interventions that address the root physiological cause. 5. Continuously reassess the patient's response to interventions and adjust the plan as needed. This iterative process ensures that care remains dynamic and responsive to the evolving needs of the pediatric patient. Question 15. The evaluation methodology shows a neonate presenting with scaphoid abdomen, diminished breath sounds on the left, and tachypnea. Given the suspected congenital diaphragmatic hernia, CDH, which of the following management strategies represents the most appropriate initial approach to respiratory support? Option A. Administer high-frequency oscillatory ventilation, HFOV, immediately to minimize lung injury and improve gas exchange. Option B. Provide gentle ventilation with permissive hypercapnia and low tidal volumes, focusing on chest X-ray confirmation and preparation for potential ECMO. Option C. Initiate mechanical ventilation with high tidal volumes and positive end expiratory pressure, PEEP, to ensure adequate oxygenation and ventilation. Option D. Administer surfactant therapy and initiate non-invasive positive pressure ventilation, NIP, to support spontaneous breathing efforts. Correct answer is C. Initiate mechanical ventilation with high tidal volumes and positive end expiratory pressure, PEEP, to ensure adequate oxygenation and ventilation. Explanation. The evaluation methodology shows that a neonate presents with signs suggestive of congenital diaphragmatic hernia, CDH. This scenario is professionally challenging due to the critical nature of CDH, which can lead to severe respiratory compromise and hemodynamic instability. The immediate need for accurate diagnosis and appropriate management, particularly ventilation strategies, and potential need for extracorporeal membrane oxygenation (ECMO), requires a rapid and precise clinical response. The complexity lies in balancing the need for respiratory support with the risk of barotrauma and volatrauma, especially in a patient with underdeveloped lungs and potential pulmonary hypoplasia. The correct approach involves a systematic evaluation, prioritizing stabilization and diagnostic confirmation. This includes immediate assessment of respiratory status, oxygenation, and ventilation, followed by imaging to confirm the diagnosis of CDH. Management then focuses on gentle ventilation strategies to minimize lung injury, such as permissive hypercapnia and low tidal volumes, while preparing for potential ECMO if conventional support fails. This aligns with established clinical guidelines for CDH management, emphasizing the principle of do no harm by avoiding aggressive ventilation that could worsen pulmonary hypertension or lung damage. Regulatory frameworks for neonatal care, such as those overseen by the American Academy of Pediatrics, OP, and relevant professional bodies, underscore the importance of evidence-based practice and patient safety in managing critical congenital anomalies. An incorrect approach would be to immediately initiate aggressive mechanical ventilation with high pressures and tidal volumes in an attempt to rapidly normalize blood gases. This strategy fails to acknowledge the delicate pulmonary vasculature in CDH and the risk of iatrogenic lung injury, potentially exacerbating pulmonary hypertension and leading to right heart failure. Ethically, this approach violates the principle of beneficence by potentially causing more harm than good. Another incorrect approach would be to delay diagnostic imaging or definitive respiratory support while awaiting specialist consultation for non-emergent reasons. This neglects the urgency of the situation and the potential for rapid deterioration, contravening the ethical duty to act promptly in the patient's best interest. Regulatory guidelines for emergency care emphasize timely assessment and intervention for life-threatening conditions. A further incorrect approach would be to proceed with surgical repair without adequate preoperative stabilization and diagnostic confirmation. While surgery is definitive, performing it in an unstable patient can significantly increase morbidity and mortality. This overlooks the critical role of respiratory and hemodynamic management in optimizing the patient for surgical intervention, a principle supported by best practices in pediatric surgical care. The professional reasoning process for such a situation involves a rapid assessment of the ABCs: airway, breathing, circulation, followed by a structured diagnostic workup. This includes considering the differential diagnosis, but with a high index of suspicion for CDH given the presentation. Management decisions should be guided by current evidence-based guidelines and institutional protocols, with a constant reevaluation of the patient's response to interventions. Collaboration with a multidisciplinary team, including neonatologists, pediatric surgeons, respiratory therapists, and nurses, is paramount. The decision to initiate ECMO should be based on established criteria and a thorough understanding of its risks and benefits, always prioritizing the patient's overall well-being and long-term outcomes. Question 16. Benchmark analysis indicates that a 3-day-old neonate diagnosed with bronchopulmonary dysplasia, BPD, is exhibiting increased respiratory effort, characterized by retractions and tachypnea, despite being on mechanical ventilation. The current ventilator settings are delivering a tidal volume of 5 ml/kg with a peak inspiratory pressure of 22 cm/H2O and a PEEP of 8 cm/H2O. Which of the following approaches best addresses the assessment and management of this neonate's pulmonary mechanics? Option A. Systematically evaluate the neonate's pulmonary compliance and resistance by analyzing ventilator-derived parameters and waveforms, and consider obtaining a static pressure-volume curve to assess lung elasticity and identify potential causes of increased work of breathing. Option B. Immediately increase the peak inspiratory pressure to 25 cm/H2O to overcome the increased resistance and improve tidal volume delivery. Option C. Decrease the PEEP to 5 cm/H2O to reduce intrinsic PEEP and allow for easier exhalation. Option D. Focus on sedation and paralysis to reduce the neonate's spontaneous respiratory effort and perceived work of breathing. The correct answer is A. Systematically evaluate the neonate's pulmonary compliance and resistance by analyzing ventilator-derived parameters and waveforms, and consider obtaining a static pressure-volume curve to assess lung elasticity and identify potential causes of increased work of breathing. Explanation. Scenario analysis. This scenario presents a common clinical challenge in neonatal respiratory care. A neonate with suspected bronchopulmonary dysplasia, BPD, exhibiting increased work of breathing. The professional challenge lies in accurately assessing the underlying cause of the increased work of breathing and implementing appropriate interventions, balancing the need for effective ventilation with the risk of further lung injury. The neonate's immature respiratory system and potential for rapid decompensation necessitate a nuanced understanding of pulmonary mechanics and their clinical manifestations. Careful judgment is required to differentiate between intrinsic lung disease, extrinsic factors, and ventilator-induced issues. Correct approach analysis. The correct approach involves a systematic evaluation of the neonate's pulmonary mechanics, focusing on identifying the specific factors contributing to the increased work of breathing. This includes assessing compliance and resistance, which are fundamental parameters in understanding the lung's ability to expand and the airflow resistance. By analyzing the pressure-volume curve, a clinician can gain insights into the elastic properties of the lungs and chest wall and identify potential issues like alveolar collapse or overdistension. Understanding how these mechanics are affected in neonates, who have smaller airways and less developed respiratory muscles, is crucial. This approach aligns with the principles of evidence-based practice and patient-centered care, aiming to optimize respiratory support while minimizing iatrogenic harm, as guided by established neonatal respiratory care guidelines. Incorrect approaches analysis. An approach that solely focuses on increasing ventilator support without a thorough assessment of pulmonary mechanics risks exacerbating existing problems. For instance, blindly increasing tidal volume or pressure without understanding the compliance of the lungs could lead to volitrauma or barotrauma, particularly in a neonate with already compromised lung tissue. Similarly, an approach that neglects to consider airway resistance might lead to ineffective ventilation and increased patient distress. Another incorrect approach would be to attribute the increased work of breathing solely to patient effort, without investigating potential underlying mechanical limitations or ventilator dysynchrony, which could delay appropriate therapeutic interventions. Professional reasoning. Professionals should employ a systematic decision-making framework that begins with a comprehensive clinical assessment, including vital signs and physical examination. This is followed by a review of the patient's history and current ventilator settings. The next step involves utilizing diagnostic tools to assess pulmonary mechanics, such as analyzing ventilator waveforms for compliance and resistance, and potentially performing a static pressure-volume loop if indicated and feasible. Based on this data, the clinician can then formulate a differential diagnosis for the increased work of breathing and develop a targeted treatment plan. This iterative process of assessment, intervention, and reassessment is critical for optimizing care and ensuring patient safety. Question 17. System analysis indicates a neonate is experiencing severe metabolic acidosis with a critically low pH, requiring immediate intervention to prevent irreversible organ damage. The parents, citing deeply held religious beliefs, refuse the recommended intravenous bicarbonate therapy and express concerns about the potential side effects of aggressive respiratory support. As the neonatal/pediatric respiratory care specialist, what is the most ethically and professionally appropriate initial approach? Option A. Immediately initiate the recommended treatment, explaining to the parents that the infant's life is at stake and their beliefs cannot override medical necessity. Option B. Immediately escalate the situation to the hospital ethics committee and legal counsel without further discussion with the parents, as their refusal presents a clear ethical conflict. Option C. Inform the parents that their refusal of treatment will be documented, and the medical team will proceed with the intervention as deemed medically necessary, regardless of their consent. Option D. Engage in a detailed, empathetic conversation with the parents to understand their specific concerns, explain the clinical rationale and risks/benefits of the proposed treatment, and explore potential compromises or alternative approaches that align with medical goals and their values. Correct answer is A. Immediately initiate the recommended treatment, explaining to the parents that the infant's life is at stake and their beliefs cannot override medical necessity. Explanation. Scenario analysis. This scenario presents an ethical dilemma where a clinician must balance the immediate needs of a critically ill neonate with the family's deeply held beliefs, which may conflict with standard medical recommendations. The challenge lies in respecting parental autonomy and cultural/religious values, while upholding the professional obligation to provide the best possible care and advocate for the infant's well-being, particularly when the recommended treatment directly addresses a life-threatening acid-base imbalance. Navigating this requires sensitivity, clear communication, and a thorough understanding of both ethical principles and relevant regulatory guidelines. Correct approach analysis. The correct approach involves engaging in a structured, empathetic, and collaborative discussion with the parents. This includes clearly explaining the neonate's critical condition, the specific acid-base imbalance, e.g., severe metabolic acidosis, its physiological consequences, and the rationale behind the recommended intervention, e.g., bicarbonate administration, or mechanical ventilation adjustments. The clinician must actively listen to the parent's concerns, explore the origins of their objections, and attempt to find common ground or alternative solutions that align with medical necessity and their beliefs, if possible, without compromising the infant's life. This approach respects parental rights while fulfilling the clinician's duty of care and adhering to ethical principles of beneficence and non-maleficence, as well as potentially relevant guidelines on shared decision-making and informed consent within the specified regulatory framework. Incorrect approaches analysis, refusing to discuss the treatment options or dismissing the parent's concerns outright represents a failure to uphold the ethical principle of respect for persons and parental autonomy. It also violates professional communication standards and can lead to a breakdown in trust, potentially hindering future care. This approach fails to explore the underlying reasons for the parent's objections and does not attempt to find a mutually agreeable path forward, thereby not acting in the infant's best interest by alienating the primary caregivers. Proceeding with the treatment without obtaining informed consent or making a genuine effort to address the parent's objections, even if they are based on religious or cultural beliefs, constitutes a significant ethical and potentially legal violation. This disregards parental rights and could be construed as battery or a breach of professional conduct, failing to adhere to the principles of informed consent and shared decision-making, which are fundamental in pediatric care. Immediately deferring the decision to a hospital ethics committee without first attempting direct, empathetic communication and exploration of alternatives with the parents is premature. While ethics committees are valuable resources, the primary responsibility for patient care and family communication rests with the bedside clinician. This approach bypasses the opportunity for direct resolution and can be perceived as an abdication of responsibility, failing to engage in the initial, crucial steps of ethical conflict resolution. Professional reasoning. Professionals should employ a decision-making framework that prioritizes open communication, empathy, and a thorough understanding of the clinical situation and the family's perspective. This involves 1. Clinical assessment, clearly understanding the neonate's acid-base status and the urgency of intervention. 2. Communication, engaging in clear, jargon-free explanations of the diagnosis, prognosis, and treatment options, actively listening to parental concerns. 3. Ethical exploration, identifying the core ethical conflict, e.g., parental autonomy vs. infant's well-being. 4. Collaborative problem-solving, seeking solutions that respect parental values while ensuring the infant receives necessary care. 5. Consultation, involving other disciplines, e.g., social work, chaplaincy, ethics committee, when direct resolution is challenging, but only after initial attempts at direct communication have been made. Question 18. Upon reviewing a 4-month-old infant presenting with a 3-day history of worsening cough, nasal congestion, and increased work of breathing, including audible wheezing and subcostal retractions, what is the most appropriate initial diagnostic and management strategy for a neonatal/pediatric respiratory care specialist, adhering strictly to U.S. regulatory frameworks and NPS scope of practice? Option A. Discharge the infant home with a nebulizer and instructions for home oxygen therapy. Option B. Initiate bronchodilator therapy and prescribe a course of oral corticosteroids to reduce airway inflammation. Option C. Focus on supportive care including oxygen saturation monitoring, ensuring adequate hydration, and facilitating airway clearance, while considering viral testing if clinically indicated. Option D. Administer broad-spectrum antibiotics and obtain a chest X-ray to rule out pneumonia. The correct answer is D. Administer broad-spectrum antibiotics and obtain a chest X-ray to rule out pneumonia. Explanation. This scenario presents a common clinical challenge in neonatal and pediatric respiratory care, differentiating between viral bronchiolitis and other respiratory illnesses in infants, particularly when the presentation is atypical or severe. The professional challenge lies in accurately diagnosing bronchiolitis, understanding its pathophysiology driven by viruses like RSV, and implementing appropriate supportive care within the established regulatory and ethical frameworks governing pediatric respiratory specialists. Misdiagnosis or delayed appropriate management can lead to significant morbidity, including respiratory failure and prolonged hospitalization, underscoring the need for precise clinical judgment. The correct approach involves a comprehensive assessment that integrates clinical presentation, patient history, and diagnostic findings to confirm bronchiolitis and guide supportive management. This aligns with the NPS scope of practice, which emphasizes evidence-based care and patient safety. Specifically, recognizing the characteristic wheezing, tachypnea, and retractions in an infant, coupled with a history suggestive of viral exposure, points towards bronchiolitis. Management should focus on optimizing oxygenation, hydration, and airway clearance, as per established clinical guidelines and regulatory mandates for respiratory care. This approach prioritizes patient well-being and adherence to professional standards. An incorrect approach would be to immediately initiate broad-spectrum antibiotic therapy without clear evidence of bacterial co-infection. This is a regulatory and ethical failure because bronchiolitis is primarily a viral illness, and antibiotics are ineffective against viruses. Unnecessary antibiotic use contributes to antimicrobial resistance, a significant public health concern addressed by regulatory bodies. Furthermore, it deviates from evidence-based practice and may mask or delay the diagnosis of the underlying viral etiology. Another incorrect approach would be to solely rely on chest X-ray findings to diagnose bronchiolitis. While a chest X-ray can rule out other conditions like pneumonia, it is often nonspecific for bronchiolitis and may show hyperinflation or parabronchial thickening, which are common in many viral respiratory infections. Over-reliance on imaging without a thorough clinical assessment can lead to misdiagnosis and inappropriate treatment, violating the principle of providing the most effective and least invasive care as mandated by professional guidelines. A third incorrect approach would be to discharge a neonate with moderate to severe respiratory distress due to bronchiolitis without adequate parental education and clear follow-up instructions. This poses a significant risk to the infant's well-being and represents a failure in patient advocacy and care continuity, which are core ethical and regulatory responsibilities of a respiratory care specialist. Ensuring parents understand warning signs, feeding strategies, and when to seek immediate medical attention is crucial for preventing readmissions and complications. Professional decision-making in such situations requires a systematic approach. First, gather a thorough history and perform a comprehensive physical examination. Second, consider diagnostic tests judiciously to confirm the diagnosis and rule out differential diagnoses. Third, develop a management plan focused on supportive care tailored to the patient's condition and age. And finally, ensure effective communication and education with the patient's family, adhering to all relevant professional standards and regulatory requirements for pediatric respiratory care. Question 19. Governance review demonstrates a 3-day-old neonate presenting with sudden onset of severe respiratory distress, desaturation, and unilateral decreased breath sounds. Initial assessment suggests a potential pulmonary air leak. Considering the regulatory framework for neonatal/pediatric respiratory care specialists, NPS, which of the following diagnostic and management strategies represents the most appropriate and compliant course of action? Option A. Administer a bronchodilator and surfactant therapy, as these are common interventions for respiratory distress in neonates, and monitor for clinical improvement. Option B. Focus on optimizing the current conventional mechanical ventilation settings and increasing positive end expiratory pressure, PEEP, to improve oxygenation without further diagnostic imaging. Option C. Immediately initiate high-frequency oscillatory ventilation, HFOV, to provide lung protective support while awaiting chest X-ray results. Option D. Obtain a portable chest X-ray urgently to confirm the presence and location of an air leak, and then proceed with appropriate ventilatory adjustments or chest tube insertion based on findings. The correct answer is C. Immediately initiate high-frequency oscillatory ventilation, HFOV, to provide lung protective support while awaiting chest X-ray results. Explanation. This scenario presents a professionally challenging situation due to the critical nature of a neonatal pulmonary air leak and the immediate need for accurate diagnosis and effective management. The challenge lies in differentiating between various types of air leaks, understanding their underlying pathophysiology, and implementing interventions that align with current best practices and regulatory guidelines for neonatal respiratory care. Careful judgment is required to avoid delays in treatment, which can lead to significant morbidity and mortality in this vulnerable population. The correct approach involves a systematic evaluation of the infant's clinical presentation, including respiratory distress, decreased breath sounds, and potential hemodynamic instability, followed by diagnostic imaging to confirm the presence and type of air leak. This is then coupled with appropriate management strategies, which may include conservative measures like optimizing ventilation settings or more invasive interventions such as chest tube insertion, all guided by established protocols and expert consultation. This approach is justified by the regulatory framework for neonatal/pediatric respiratory care specialists, NPS, which mandates adherence to evidence-based practices and patient safety standards. The NPS scope of practice emphasizes the importance of prompt and accurate diagnosis and management of respiratory emergencies, ensuring that interventions are timely and appropriate for the specific condition and patient. An incorrect approach of delaying diagnostic imaging after initial suspicion of an air leak would be a significant regulatory and ethical failure. This delay could lead to worsening pneumothorax, tension pneumothorax, and subsequent cardiopulmonary compromise, directly violating the NPS duty to provide timely and effective care. Another incorrect approach of initiating aggressive ventilatory support without confirming the air leak or considering its specific type could exacerbate the condition, potentially causing further lung injury or barotrauma, which is contrary to the principle of do no harm and established clinical guidelines. Finally, an incorrect approach of solely relying on clinical assessment without corroborating diagnostic evidence would be professionally unacceptable, as it bypasses crucial diagnostic steps mandated by best practices and regulatory oversight for ensuring patient safety and optimal outcomes. A professional reasoning process for similar situations should involve a rapid assessment of the patient's condition, a thorough understanding of the pathophysiology of neonatal pulmonary air leaks, and a clear recall of diagnostic and management algorithms. This includes recognizing the signs and symptoms suggestive of an air leak, knowing when and how to utilize diagnostic tools like chest X-rays or ultrasound, and understanding the indications and contraindications for various therapeutic interventions. Adherence to institutional protocols and consultation with neonatology and pediatric surgery teams are also critical components of effective decision-making in these high-stakes scenarios. Question 20. Governance review demonstrates a neonate on volume-controlled mechanical ventilation is exhibiting increased respiratory effort, frequent alarms for high peak inspiratory pressure, and desaturation despite adequate oxygenation. The respiratory therapist suspects ventilator dysynchrony and increased work of breathing. Considering the need to optimize patient ventilator synchrony and reduce the risk of barotrauma, which of the following adjustments to the ventilation strategy is most appropriate? Option A. Increase the fraction of inspired oxygen, FiO2, and administer a bronchodilator. Option B. Switch to synchronized intermittent mandatory ventilation, SIMV, with pressure support, adjusting pressure support levels to reduce the neonate's work of breathing. Option C. Discontinue mechanical ventilation and initiate nasal cannula oxygen therapy. Option D. Increase the tidal volume and decrease the respiratory rate in the current volume-controlled mode. The correct answer is D. Increase the tidal volume and decrease the respiratory rate in the current volume-controlled mode. Explanation. This scenario presents a common yet critical challenge in neonatal and pediatric respiratory care. Managing a neonate on mechanical ventilation who exhibits signs of distress and potential ventilator dysynchrony. The professional challenge lies in accurately interpreting the patient's clinical presentation, understanding the underlying physiological mechanisms, and selecting the most appropriate ventilator mode and settings to optimize gas exchange and minimize iatrogenic harm, all while adhering to established clinical guidelines and regulatory standards. The need for rapid, evidence-based decision-making under pressure is paramount. The correct approach involves a systematic assessment of the neonate's respiratory status, including vital signs, blood gas analysis, and direct observation of the ventilator waveform and patient effort. Recognizing that the neonate is experiencing increased work of breathing and potential asynchrony, the most appropriate intervention is to switch to a pressure-controlled mode that synchronizes with the patient's spontaneous efforts, such as synchronized intermittent mandatory ventilation, SIMV, with pressure support, or assist control ventilation in pressure control mode. This allows for patient-triggered breaths at a set pressure, reducing the work of breathing and promoting better synchrony. Regulatory frameworks for respiratory care specialists, such as those outlined by professional bodies and accrediting agencies in the U.S., emphasize patient safety, evidence-based practice, and the use of appropriate technology to achieve optimal outcomes. Adhering to these guidelines ensures that interventions are not only clinically sound, but also meet the highest standards of care. An incorrect approach would be to simply increase the respiratory rate or tidal volume in a volume-controlled mode without addressing the underlying dysynchrony. This could lead to increased intrathoracic pressure, barotrauma, and further patient distress, potentially violating the principle of do no harm, which is a cornerstone of medical ethics and regulatory compliance. Another incorrect approach would be to discontinue mechanical ventilation prematurely without adequate spontaneous respiratory effort or gas exchange, which could result in hypoxemia and hypercapnia, again contravening the goal of providing appropriate respiratory support. Failing to consider pressure support in conjunction with SIMV or assist control modes, or to adjust pressure levels based on patient response, represents a failure to optimize the ventilation strategy and could lead to suboptimal outcomes, potentially falling short of the expected standard of care as defined by professional practice guidelines. The professional reasoning process should involve a rapid assessment of the patient's current ventilatory status, identification of potential causes for distress, e.g., bronchospasm, secretions, ventilator dysynchrony, consideration of available ventilator modes and their physiological effects, and selection of the mode and settings that best address the identified issues while minimizing risk. This process is guided by clinical expertise, institutional protocols, and regulatory requirements that mandate competent and safe patient care.